Welcome, everyone. Thank you for joining us for today's webinar. My name is Suzanne Toppy, and I'm an editorial director here at Springer Publishing. For those of you who don't know Springer Publishing, we are an award-winning publisher of nursing and healthcare content featuring books, apps, journals, and digital products. Today, we are presenting EKG Interpretation, Taking Students from Scared to Prepared, presented by Maureen Knechtel. Maureen is a physician assistant who received a bachelor's degree in health sciences and a master's degree in physician assistant studies from Duquesne University in Pittsburgh, Pennsylvania. She has spent her clinical career specializing in general cardiology and cardiac electrophysiology. She teaches EKG recognition and interpretation to both physician assistants and nurse practitioners and has been a guest lecturer nationally and locally on topics including EKG interpretation, chronic angina, ischemic heart disease in women, hypertension, and mixed hyperlipidemia. Maureen Knechtel is a fellow member of the American Academy of Physician Assistants and the Tennessee Academy of Physician Assistants. She is also associate professor and academic coordinator with the Milligan University Physician Assistant Program in Northeast Tennessee. Before we get started, I want to mention that this webinar will last approximately 40 minutes with an opportunity for questions and answers at the end. The presentation will be recorded and available to view with the slide deck on springerpub.com/videos in the next 5 to 7 days. You will receive an email with that link to the recording. If you have any questions, please type them in the question box in your Zoom control panel. They will be shared with the presenter at the end of the presentation. If you forgot to ask a question, there will be a brief survey sent at the end of the webinar, and you can include your question there. Now, without further ado, let's turn the presentation over to Maureen Knechtel.
Good afternoon, everybody. Thank you for joining us today for the webinar. My goal with this presentation today is to help you feel more comfortable with presenting the topic of 12-lead EKG interpretation. Oftentimes, as medical educators, we are tasked with the job of presenting topics that maybe we don't feel 100% comfortable with. EKGs is one of those topics that if you don't use that information every day, you might not feel as comfortable with it, and certainly teaching it presents another challenge. So my goal for today is to help you understand the value in teaching a systematic approach to EKG interpretation, learn how you want to organize the contents of an EKG presentation that you're presenting to PA and NP students, and then develop and refine your own approach to teaching EKGs based on your program goals. You may find that you want to expand on what we talk about today, and you may want to take away from some of what we talk about. You can choose to do that based on whatever you want to accomplish with your program. I like to divide my EKG lectures into multiple sections. And the first section I'll talk about is the basics. And I often find that sometimes it's helpful to give students some assigned readings ahead of time, because these things are fairly basic and you want to be able to just review them and spend the bulk of your time in the classroom really going over examples and some of the more complex things. So I start by a review of the anatomy and physiology. We look at things like where's the sinus node and the AV node and the ventricles, and what is the hierarchy there of who's in charge. So how does that work from the sinus node to the AV node to the ventricles? We define the intervals, PR versus QRS versus QT, and how can I apply that clinically? And as part of that, we talk about the components of the QRS and how we label them. So what constitutes a Q wave versus an S wave, for example. And then the last component of this is the most complicated, and that's the lead review. So we talk about where we place the leads on the human body and how those leads interact with each other to create what we see on the EKG print-off. I lay the basics here, and then I always try and incorporate these throughout my systematic approach later. Another component that's helpful here is always try and tie things in from a clinical perspective. EKGs are fairly abstract, so anytime you can bring it back to something clinically relevant, that tends to hold a student's attention a little bit better. So let's talk first about estimating the intervals. When you pick up an EKG, you want to start by saying this is, in general, 10 seconds of time is a standard EKG. And we look at the rhythm strip along the bottom, that's 10 seconds. And then each individual lead is about 2.5 seconds. So the rhythm strip is going to give us a lot of really helpful information when we're evaluating things like arrhythmias. Other intervals we can look at, one large box is 0.2 seconds or 200 milliseconds. And that's a really helpful interval for estimating things like a first-degree AV block. One small box is 0.04 seconds or 40 milliseconds. And I know if I have a QRS duration, for example, that's more than 3 small boxes, then I have an interventricular conduction delay. So that's another way we can use that. And then finally, in terms of the boxes, 1 small box is 1 millimeter. So if I want to quickly estimate things like ST depression or ST elevation from baseline, I can estimate those very easily by just looking at 1 box, 1 small box. And then finally, the last thing I'll review is if you're not sure how long an EKG is this a standard EKG? You can always count up the number of large boxes in a rhythm strip, and there should be 50 of them in a 10-second strip. And at the top corner here of this slide, you can see the picture of the P versus a QRS versus the ST. And another thing I'll sometimes do is offer a formative quiz, so an ungraded quiz at the beginning of our lecture time after their reading. And that's helpful for things like self-assessment, where they can say, oh, I didn't quite get that, I need to look at that again. The final section is the lead review. And in this picture here, this is where you can really start to lose students. So I try to keep it very simple, and I present the lead review in terms of setting things up for the cardiac axis. So we look at the leads that are placed, the limb leads that are placed on the body, and then I go over first leads 1, 2, and 3, because that creates Einthoven's triangle where the heart just sits there in the center. So from leads 1, 2, and 3, I can orient those in a triangle, picture the heart in the center, and then at right angles, I can draw in additional leads, AVR, AVL, and AVF, from which to gain more angles to view electrical activity from within the heart. Finally, I can take all of those leads and intersect at a common central point, and now I have my cardiac axis wheel. Let me just pull up a line here where I can show you. So what I'm talking about here is this drawing over here, the cardiac axis wheel. So if I were just to kind of take that and just flip it and superimpose it on your left chest where the heart is, we imagine the base of the heart being up in this area and then sending electrical activity down this way. So just like this, that's the normal electrical vector. As electricity moves away from a particular area of the heart, the leads that represent that area of the heart will see those impulses as negative. And as it moves towards a particular lead, those leads will see that electrical activity as positive. And that's what causes the QRS to be either positive or negative in a given lead. So I'll explain to students, this concept is helpful with cardiac axis and with other things like bundle branch blocks that we'll go over later. So always try and take the vantage point of what lead am I looking at, and is electricity moving towards me or away from me? And I can use all 12 leads to really get a nice picture of all the electrical activity in the heart from multiple different angles. Clear this off here. Okay, so after we go over our basics, then we'll move into our systematic approach. And this is where you want to spend the bulk of your time. I will usually divide this up into 2 separate lectures because you don't want to overload students with too much. So I cover rate, rhythm, and axis first, and then I'll give lots of examples, and then I'll do heart block, ischemia, and everything else in a second lecture. That gives students time to really kind of digest things and think about if they have any questions. There's lots of different things you can look at, but for me, a systematic approach involves what is the rate? Is the rhythm regular or irregular? Is the axis normal left or right? Is there any heart block? And is there any ischemia? For everything else, I've got a slide later to show you some things you may choose to cover there. For instance, things like ventricular hypertrophy you can cover there. When you're organizing your lectures, it's helpful to remember, I just need to focus on what they can't miss. So maybe you spend less time differentiating between types of PSVT, for example, but you should certainly spend plenty of time making sure they understand what a STEMI looks like on EKG, because that's what we can't miss. So for me, it's helpful when organizing my thoughts and deciding what can I include versus what can I take out. Well, I try to think about it from a competency approach. What must they be competent in? And that's what I include. So let's start with calculating the rate. There are several different ways we can calculate rate. I try to pick just a couple so I don't overwhelm students, and I pick the ones that I think are the easiest. So what we're looking at here is what is the RR interval. So we can use the 300 method. That's where I find a QRS or an R wave that falls on a thick, dark line on a large box. And then I count over to the next dark line using 300, 150, 100, 75, 60, 50, 40. And I can very quickly estimate what the heart rate is. So this is what I use most of the time in clinical practice, and it's an easy thing to teach students. All of this is based off of a heart rate of there being 60 seconds in a minute. And we can calculate this using the 300, 150, 100 method, because if one large box is 0.2 seconds, then the rate is 60 divided by 0.2, and that's where I get that 300 number. I don't offer that, but students always ask me that question, and so then you want to explain the why, because I like when students ask the why. Now, let's say your heart rate is, the rhythm is irregular. How can I calculate the rate then? Because this doesn't work. Or what if the rate is slow, less than 40 beats per minute? Then the next method we can use is simply count the number of QRS complexes in a 10-second rhythm strip, and I multiply by 6, and that gives me my heart rate. That's also a really, really quick and easy way to calculate heart rate. So step number 1, what is the rate? 60 to 100 is normal. If it's faster than 100, then it's tachycardia. If it's slower than 60, then it's bradycardia. Then we move into our next step, which is rhythm. So with rhythm, really what we're trying to determine here is, are the QRSs following a pattern? Are they predictable, or are they not predictable? So 3 things we're looking at are the QRSs regular? Are they regularly irregular? Or are they irregularly irregular? Anytime you can group things like that, it works well for learning, because now I've got a built-in differential diagnosis for something for each one of those. So we're looking for a pattern to the QRS complexes. I've already established the rate in step number 1. Now I'm moving on to rhythm. So if the rhythm is very regular and I've got a very predictable QRS pattern where I can say I know when the next one's going to come, then I look at the P wave. That's my next step. So whether it's regular or irregular, I want to establish what is the relationship of the P wave to the QRS, because that's going to hold the key to my diagnosis of that rhythm. So evaluate the P wave, its relationship to the QRS, and now we'll be able to figure out what the rhythm is. So let's apply that to a couple examples. So regular rhythms that are sinus in origin, here's some examples here. The top example right here, if I go through step number 1, I've already established that the rate is tachycardic. So I start with a QRS on a thick dark line, and I count over 300, 150, 100. So I'm right about 140, 145 beats per minute. Next step, look at the P wave. So I see a normal appearing P wave before every QRS, and they are associated. So now I can very easily say this is sinus tachycardia. And I apply the same one to this example here, where I can see that the rate is slow, but when I look at the P wave and its relationship to the QRS, it looks normal. So I can say that it's sinus bradycardia. So of course, not everything is sinus in origin. So let's say the rhythm is regular, but it looks like this. So I can see there are predictable QRSs occurring. But then when I look to evaluate the P wave, I do not see a normal appearing P wave. It looks like atrial flutter. So very quickly, I've established the diagnosis just by those first 2 steps of what is the rate and then what is the rhythm. And I do that by evaluating the relationship of the P wave to the QRS. Let's look at our second category, which would be regularly irregular. So this is when I can see patterns of regularity intermixed with some irregularity. So I see periods of regular rhythm, and then every so often there's a beat that's coming in early. So my differential diagnosis for something like this would be ectopy is the first thing. I think about atrial or ventricular ectopy. And then something else I might consider would be like a Mobitz type 1 second-degree heart block, because that's also something that has a repetitive pattern. But if I'm looking at it, or I tell students, imagine you had your eyes closed and you're listening with a stethoscope. What is that going to sound like? Is it going to be perfectly regular, or is it going to be slightly irregular? So if I think about common things happening commonly, PACs and PVCs are a very common cause of regularly irregular rhythms. Something that also creates some confusion for students, PAC versus PVC. So I like to introduce this concept here, and then I bring it back in when I cover arrhythmias, and I'll show you where I do that later. So if I'm going through my pattern, I say, okay, this is slightly irregular, but there's some regularity to it. Next step, evaluate the P wave, because I already know what my differential diagnosis is. So in the first example here on the top, if I look at this, I can say, I can see a period of regularity in the middle, and then here's a beat that looks like it comes in a little bit early. So then I think, what's driving the train here? What's starting this? Is it A, atria, or is it the V, the ventricles? And I can evaluate a P wave right here where this arrow is. So here's my P wave, and it looks like it is associated with the QRS that comes after it. And you'll notice also that P wave looks a little bit different. So this is a great opportunity to introduce this concept of if there's atrial activity from somewhere other than the sinus node, look how it looks slightly different. And that really is the key to my diagnosis. So this one looks like it comes in a little bit early, this P wave, but there's a normal QRS, a slight resetting with a pause, and then everything goes back to normal until I see an early beat come in again. Same concept with the second example down lower here, where I'm stringing together some PACs. My main job is to differentiate between atrial or ventricular, and if I evaluate the P wave and its relationship to the QRS, that's how I can best do that. And let's look at our other example of ventricular ectopy. And the first example here, I can see these periods of regularity followed by irregularity. And so this beat right here is coming in a little bit early, just like this one is, and this one, and this one. So when I try to evaluate what's driving the train, is it the A or the V? I can't really define a P wave coming in there. I don't really see a P wave, but I do notice that the QRS is very wide, and then there appears to be a different appearance to that T wave than the surrounding T waves. And that's because there's a P wave buried in there. So a couple things I can clue in here for my diagnosis: early beat, a little bit of a pause where it resets and then the pattern repeats itself. The QRS is very wide, and I don't see a P wave occurring before the QRS. So that's how I can say that this is ventricular in origin, and it's a regularly irregular rhythm. The final category we have is irregularly irregular, and the best example here is atrial fibrillation. I cannot tell you, I can't anticipate when the next QRS is going to come in. It's irregular, it's erratic, and then my next step being the evaluation of the P wave, I don't clearly see a P wave here. I see fibrillatory waves in between R waves, and that's consistent with atrial fibrillation. Okay, so we talked about rate, we've covered rhythm, looking at regular, regularly irregular, or irregularly irregular, and creating our differential diagnosis. And then the second component of rhythm is the evaluation of the P wave and its relationship to the QRS. So I'll pose a question to you then. What is one potential cause of an irregularly irregular rhythm other than atrial fibrillation? Okay, looks like the majority got it right. Variable atrial flutter. So I put this this question in there because, as I mentioned, it's good to tie things in from a clinical standpoint, and it's great if we can create nice little boxes where stuff fits. So if I think about rhythm in terms of a differential diagnosis, an irregularly irregular rhythm could be atrial fibrillation, but it could also be a variable atrial flutter. So I could have a 3-to-1 that transitions to a 4-to-1 and then a 2-to-1 flutter, and that's going to give me a variable QRS. So I like to point this out to students and also clinicians, because sometimes we see an irregularly irregular rhythm and we automatically think atrial fibrillation. And it's important to recognize that atrial flutter can do that also. In my little box of a differential diagnosis, PSVT, a monomorphic VT, and a sinus tach, those are going to be very regular rhythms. So it really helps you differentiate in your mind, what could this rhythm be? So thank you all for participating in that. So let's move on to our next step, which is axis. So axis, I don't know about any of you, but when I learned EKGs, axis is where I about threw in the towel. I thought it was pretty confusing. So I think that axis, if you work in electrophysiology like I do, then yes, I need to know the exact number. Where does that axis fall? But for most people, especially if you're working in primary care, if you can tell me it's normal left or right, that is fantastic, and that is right where you need to be. So let's look at some tips and tricks of how we can teach this. So the cardiac axis, think back to my previous slides that I had there about the lead review in our cardiac axis wheel and how we create that. And then what's really important here is to remember that concept of if electricity moves away from something, those leads are going to see it being negative. If electricity moves towards it, those leads are going to see it being positive. And when I just want to know normal left or right, all I really need to do is look at the QRS and leads 1 and lead AVF, because those are the two leads that create my 4 quadrants. So if I can tell where the QRS is up or down in each of those leads, I can localize the general axis to one of those quadrants. Because remember, our cardiac axis tells me the general direction of electrical flow through the heart. And if we take this cardiac axis wheel, put it on my left chest, I should see electricity move in this direction. And think about it this way too. Precordial leads are a great example of this. Lead V1, if you pick up a given EKG and look at leads V1 and V2, the general direction of those complexes is going to be negative. So just like it is in this example, it's going to be down and not up. And that's because those leads see electricity moving away, because the electricity starts up here and it moves down. And that's exactly why lead V6 is positive. So another great example of maybe explaining R wave progression is based on this. That's why we see normal R wave progression being negative V1, V2, and then gradually transitioning to positive in V5 and V6. Okay, so let's get back to our determining the axis. So if I look just at the QRS in lead 1 and just at the QRS in lead AVF, I can determine my axis. So if we look at the cardiac axis wheel, let me get I'm going to use my mouse here so you can see. So if I look just at this cardiac axis wheel, and if I think about lead 1, normally lead 1 should be seeing electricity moving towards it. And same with lead AVF. So let's look at this example here. In lead 1, the QRS is positive. So it's positive over here. And the QRS in lead AVF is also positive. So if I use this helpful diagram to teach this method, in lead 1, the QRS is positive. So that means the axis is going to be somewhere on the patient's left. Then I look at the QRS in lead AVF. It also would, in a normal axis, should see electricity moving towards it. It should also be positive. So it would fall somewhere down here. So either to the patient's right or in the normal quadrant. So where does this over here intersect with this? Where do those overlap? They overlap in the normal quadrant. Hopefully you guys can see my drawings here. So if I look at lead 1 is positive, then the axis is going to be either here or over here. Lead AVF, if it's positive, the axis is either going to be here or over here. And if I take those two and I put them together, where do they overlap? They overlap in the normal quadrant. Another way you can do this that students like is the 2 thumbs up method, which a lot of you probably already know, but if the QRS in lead 1 is positive, I give 1 thumb up. If it's positive in AVF, that's 2 thumbs up, and that's a normal axis. So let's take those same concepts and apply them to a couple other examples. Okay, so in this example, I look at the QRS in lead 1. Here's lead 1, and it is positive. So I know the axis is either going to be normal or it's going to be left. So left or normal. And then the QRS in lead AVF is negative. So the axis is either going to be over here or it's going to be over here. So where do all of these overlap? If I were to put them together, they overlap in the left axis quadrant. And I can confirm that with my 2 thumbs up. So lead 1 is positive. The QRS in lead AVF is negative, and my left hand is positive, so it's a left axis deviation. One more example, same concept. Lead 1, the QRS is negative. Lead AVF, the QRS is positive, so it's a right axis deviation. Apply it over here to our axis wheel. The QRS in lead 1 is negative, so my axis is either going to be indeterminate or it's going to be right. And then AVF, it's positive, so it's either going to be right or it's going to be normal. So right axis quadrant is where those overlap. The last one that we didn't talk about will be this indeterminate axis up here. And if you see an axis that falls somewhere in here, then you should start thinking about ventricular tachycardia. And that makes sense too, because normally the cardiac axis should be going this way. So what in the world would cause the electrical activity to start in the apex and move up to the base? VT. So that's the thing you should think of there. Okay, so for a segue into our next topic, I'll pose a question to you based on common mistakes that students make or just misconceptions they have. Okay, so Once again, the majority got it correct. The first step in determining the presence of a bundle branch block is to measure the QRS duration. So that's the first thing we want to do. So thank you again for participating in our poll. So we've talked about rate, rhythm, and axis. Remember, at this point, this is when I would break the students into groups. You can use the see one, do one, teach one approach of education and EKGs. So I'll cover some concepts and then I'll put them in small groups and give them some examples. So they'll see me explain it, then they'll get to practice it, and then they talk about it. So I'll put people on the spot and make them in their groups, of course, explain, how did you come up with that answer? Why are you thinking that? And then it's a great way to kind of brainstorm and learn from each other too. So that's the end of that section. And now I move into heart block, ischemia, and infarction. And this is where we want to give lots and lots of examples. So next step, evaluating for heart block. So what falls under that category? First degree AV block, a bundle branch block, QT prolongation, we consider that here. And then two types of second degree AV block along with third degree AV block. First degree AV block, you might actually catch that in your rhythm section if you're looking at the correlation between a P wave and a QRS. Bundle branch block, first thing we want to look at is a QRS that's more than 3 small boxes. So students love, they love the whole, you may have heard bunny ears when we talk about a right bundle branch block where we have an RR prime in V1 and V2. And so sometimes students forget, well, the first step is there has to be a wide QRS or else we cannot have a bundle branch block. So that's step number 1. And then QT prolongation, great one where you can tie in clinical correlates like medications, ischemia, and electrolytes are the 3 things you should think of if the QT looks long. Second degree type 1 and type 2, we're going to differentiate between those. Okay, so let's start with bundle branch blocks. So if the QRS is more than 3 small boxes, I know there's an interventricular conduction delay somewhere. There's delay as electricity spreads through the ventricles. And I can tell that where the location of the conduction delay is by looking at the far right chest lead V1 and the far left chest lead V6. And I can look and see, do they see electricity moving towards them or does it see it moving away from it? And that's how I can determine which direction that passive depolarization is occurring. So let's look at an example and apply that. With the right bundle branch block, like this example, first step, QRS is wide. So if I go through my rate and my rhythm and I come to axis, and then I come to block. So with block, QRS is more than 3 small boxes. So that's step number 1. Common things happening commonly, we want to make sure there's not a bundle branch block. So then I need to look at the far right chest lead V1 and the far left chest lead V6, because remember with the chest leads, what you see is what you get. So you can really take the vantage point of V1. If you're a little person sitting on the wall of the right side of the heart, and there's a conduction delay that starts on the right, well, you're probably going to see all the electricity moving towards you because there's a conduction delay. And just like if you're a little person sitting on the wall of the left side of the heart, the wall of the left ventricle, you're going to have some intrinsic depolarization. So there'll be some positive component to the QRS, but there'll be a strong negative component as well as electricity moves away from the left side to passively depolarize over to the right. And that's exactly what we see in this example. So in lead V1, I've got 2 joined but out of sync QRS complexes representing right and left ventricular activation, but they're both positive because there's no intrinsic, you're losing that intrinsic activation of the right side. So everything's coming from the left and over. And then in lead V6, I see some intrinsic depolarization with this R wave in V6. Get my drawing here. So here's my R wave in V6, but then I've got this beautiful little S wave right here. And that is the key to the diagnosis. So I've got an RR prime in V1 or the bunny ears. And you can also see that really nicely in V2. And then in V6, I've got an RS pattern. The S wave has a very classic characteristic appearance that contributes to the QRS duration. See, it doesn't just go down and come right back up. It goes down and just kind of slowly comes back up because of that slow passive depolarization. So we can apply that same concept if we look at the left. So in a left bundle branch block, I personally think it's even a little bit easier to recognize. In a left bundle branch block, I've got these deeply negative QRS deflections in V1, and then really strongly positive QRS in lead V6. So think about this too. The left ventricle is bigger than the right ventricle. The left bundle branch is significantly bigger than the right bundle branch. So if I've got a conduction delay that's significant enough to cause a blocking there in that left bundle, then I'm going to see a pretty wide QRS duration typically. And then because I'm using so much of that real estate there with passive depolarization, I don't have the ups and downs as much as I get with the right bundle branch block. So what I see in lead V1 is because that's where the intrinsic depolarization is coming from, and then passively spreading over to the left, I see very negative deflection there in V1 and very positive deflections over in V6 as everything makes its way over from right to left. So with bundle branch blocks, your students can memorize it. Absolutely, they can memorize it, but isn't it better if they understand exactly what's happening? So I think it's a great opportunity to explain the actual pathophysiology of what's happening. Other types of heart block, we already talked a little bit about a first degree AV block. What I'll point out here is it's a great opportunity to use that estimation of intervals. I find an R wave that falls close to a thick dark line, and then I look at where the P wave starts. If it's more than one big box, then I know there's a first degree AV block there. Second degree AV block. So a second degree type 1, I don't typically have students confuse a type 1 and a type 2 that much. What they'll confuse is a type 1 with something like a PAC, because your eyes are immediately drawn to this little bit of a drop here. So right there, see a little bit of a drop? That's where your eyes go. So you start thinking, oh, maybe it's a PAC with a little bit of a pause. But a second degree type 1, I always tell students you have to be patient and you have to look at the entire rhythm strip or else you could miss it. So if we're going through our pattern of rate and then we get to rhythm, we're going to say, oh, it's a little bit irregular. It's regularly irregular. It seems to follow a pattern if I look at the entire rhythm strip. So then my next step is to look at the P wave. So I evaluate the PR interval before and after that drop beat. So here's my drop beat where the arrow is. I look at the PR interval right after and the PR interval right before. And I think we can all agree that the one right after it is a little shorter than the one before. And then here's my lonely P wave without a QRS right there. So then I say, aha, I think this is a Mobus type 1 or a Wenckebach or second degree type 1. And to confirm that, then I'm going to follow this pattern across the rhythm strip to confirm my diagnosis. And we can compare that to a second degree type 2 or a Mobus type 2, which looks quite a bit different. But again, your eyes are going to be drawn to this drop beat here. So depending on how many drop beats they have, it's typically going to have, it can have a very irregular appearance, but there's going to be patterns of regularity to it. So it tends to be regularly irregular. So first step is regularly irregular. Second step, look at the P wave. And so if I look at the PR interval all throughout the rhythm strip, it's the same. It doesn't change, it's fixed. And then I have intermittent dropped beats. The other thing you'll notice about a Mobus type 2 compared to a type 1 that's helpful clinically to point out is the location. It's what we call infrahiscine, so it's lower in the conduction system, which gives it a wider QRS appearance. And then Mobus type 2, I'm always more concerned about this because usually these patients end up with pacemakers, whereas a Mobus type 1, a lot of times they don't. We associate that with things like sleep apnea, or it could be just calcified conduction system disease medications, but a second degree type 2 is more likely to be irreversible. So this is one of the can't miss things on your EKG. And then a third degree AV block is the final type of heart block we'll talk about. If I go through my pattern of rate, typically, not always, but a third degree is typically slow. The rhythm is always regular. If we think about what's the pathophysiology of what's happening, it's an escape focus. So with this one, it's regular. But if I then move to my next step, which is evaluating the P wave and its relationship to the QRS, I'll see that there is no relationship. They're not associated. So if I look through the entire rhythm strip, I can see a P wave here and I see a P wave here. And that P wave, I don't think that's causing this QRS complex. And then here's what kind of gives it away. I've got two P waves in a row and another one right here. So this is a great example of using your calipers that I'll have students bring their calipers and measure the P to P interval and just march it across the page. And you'll see that it's perfectly regular, but it's faster than the QRSs and they're not associated. The problem students make with the third degree AV block is that they'll call it a bundle branch block. And that's easy to do because you might look at this if you weren't patient and you'd say, well, the QRS is wide and I see negative deflection in V1 and a positive in V6. So I think it's a left bundle branch block. But it has that appearance because everything above the ventricles has failed. So the AV node is not working to conduct. So I've got a ventricular escape focus that's coming in and firing at a last ditch effort, a fixed rate. And that's why it looks that way. All right, at this point in time is when I switch gears. When I teach this and I go into arrhythmias, I go into a bit more detail about atrial arrhythmias and ventricular arrhythmias. So you can pick and choose how in depth you would like to go with that section. But this, in my opinion, is a good place for it. If they're feeling pretty comfortable, they're starting to get the hang of EKGs, and now I can talk about arrhythmias and the amount of depth that however deep you want to do that. So fib, flutter, PSVT, VT, and VF are the things that I cover in addition to asystole. But if we go back to our pattern, our systematic approach, let's talk about ischemia infarction. This will be our last topic for the webinar. This is when really all 12 leads come together and get to shine. So the first thing I want to focus on with this is telling people you don't read an EKG like you read a book. You don't read it from left to right. You got by with reading from left to right with a rhythm strip or with a telemetry strip, but not with a 12-lead EKG. So immediately your eyes should start grouping things. So from the first minute I show them a 12-lead EKG, I highlight things, I color code things. I want them to automatically get in the habit of grouping these in their mind. So 1 ABL, V5, V6, lateral wall, left circumflex. 2-3 ABF, inferior wall, right coronary. And then I also want to stress the importance that of changes in contiguous leads. So if someone hands you an EKG and there's a Q wave in lead 3, so what if it's not there in 2 and AVF? So they have to be present in electrically contiguous leads in order for it to be a problem. With injury patterns, because that's our big focus, we can't miss injury patterns. I'll show them this slide and then I'll bring it back when we talk about reciprocal changes. But in this section over here, so this EKG, I can see that it looks like there's ST segment elevation, but it's in almost every single lead. So if I look at these things in groups and I'd say, well, that's weird, that doesn't make any sense, unless there's just this ischemia everywhere in the heart or injury patterns everywhere in the heart, which it wouldn't look like this. And then I can compare that to this example over here where I can say, now look over here, if I use my group pattern of EKG interpretation, look at 2 and 3 and AVF, I've got nice ST segment elevation there. Like I just pick up that J point and lift it up off the baseline. ST segment elevation, which I'm going to count in small boxes. And then I can see reciprocal changes to confirm my diagnosis here in 1 in AVL, and then also in V5 and V6, which makes sense. So we'll come back to reciprocal changes in just a minute. Sometimes those visuals are helpful for students. So you want to stress the importance of anatomy and how it relates to the conduction system as well. So these are the leads in the EKG that represent particular areas of the heart. This is the blood supply. And then don't forget about the conduction system as well. So if I've got a patient with, for instance, an inferior STEMI, and they've also got complete heart block, you could miss that if you were so focused on just the STEMI. So that's where the group pattern and the systematic approach is helpful as well, because if I go through rate, rhythm, axis, infarction, block, I'm not going to leave anything out. And that's clinically relevant because patients that have injury patterns in addition to conduction delays have a worse prognosis. Serial EKGs are vital. I've got to talk about EKGs we talk about patterns, but also repeating those EKGs, because something that starts off with some T-wave inversion can quickly progress to ST depression, ST elevation, and then if I don't intervene somewhere along that continuum, then I end up with these big old Q waves like I have in this last example there in lead V3. So serial EKGs are vital. Always repeat them because the EKG changes very quickly when there's injuries. Reciprocal changes are a really nice way to confirm our suspicion of an injury pattern. So if I think about the heart, and I usually at this one, I'll bring in a little model. I'll have a model with me in class, and I'll just kind of show them the 3D. And so we'll look at kind of how the heart sits in the chest, and then we'll talk about primary changes in terms of ST elevation or injury patterns can be confirmed by looking at the reciprocal area of the heart or kind of the mirror image. For example, if I have an acute anterior wall injury, so the anterior part of the heart, the mirror image of that is going to be in the inferior wall. So 2 leads, 2, 3, and AVF. So if I've got ST segment elevation in the anterior leads, the inferior wall is going to see just the opposite, and I'll see ST segment depression. And that's very helpful when I'm trying to differentiate between, am I kind of hallucinating ST segment elevation, or is it really there? And so if I see those reciprocal changes, then that confirms it for me. This is, and I'll also at this point show examples of how quickly things change. So where someone starts off with a little bit of ST segment elevation, and within 5-10 minutes, sometimes that can just dramatically change. And if you miss those subtle changes, then you might not think to repeat the EKG. So examples here, lots and lots of examples when we look at ischemia, injury, and infarction, because they can't miss it. So here's an example of anterior wall ischemia in leads V1 through V4. We see that nice ST segment depression, like you just take that J point and drop it, just pull it below baseline. We want to count up those small boxes. 2 or more small boxes is clinically significant in most cases. Lateral wall injury, so injury pattern is the ST segment elevation, and so I can see in 1, AVL, V5, V6, really all the way over to V2, I've got significant ST segment elevation, and I can confirm that it's an injury pattern by looking for depression in 2, 3, and AVF, which I also have here. So lots of examples of STEMIs are very helpful. And then finally, inferior wall infarct. This is where it's important to understand the concept of what constitutes a Q wave, what differentiates a Q wave from an S wave, for example. So if the first deflection of a QRS is negative before it goes up, then it's a Q wave. So this was a patient that I saw I try to use all my own EKG examples, real life examples when I teach, because if you just show them ACLS strips, they all look perfect. So I like to show them things that maybe aren't completely perfect. So in this example here, I can see big Q waves in 2, 3, and AVF, and this was someone that needed cardiac clearance before a knee replacement, so a very common situation for your students. And you want to make sure they recognize Q waves and the implications of that. So this is someone where I probably want to ask a few more questions, do a little bit more of a cardiac risk assessment before I just clear somebody for surgery without asking more questions. So that's the value of understanding Q waves. All right, so everything else that you might choose to cover in that category. So we got ventricular hypertrophy, atrial enlargement. I always cover clinical correlates, and I'll kind of do this at the end where I want them to feel a bit more comfortable with these concepts, and then I'll tie it back to clinical correlations. So electrolyte abnormalities, for example, we certainly want to talk about that. Things like PE or pericarditis are great EKG examples to show as well. When you're not sure about other things to include, I mentioned the competency type things, can't miss things. These are things that I include. You don't have to include all of them, but when I think about categorizing them, I'll add in these danger red flag EKGs. So a STEMI and of course, Wellens syndrome, which is a type of a STEMI. Those are high-grade injury patterns that we can't miss. And then high-grade AV block or a new left bundle branch block are new block patterns that we can't miss, because a new left bundle, we're certainly concerned about things like active injury patterns or ischemia. And then I cover prolonged QTC, Brugada pattern, and a delta wave, along with wide complex tachycardia for arrhythmias. These are all things that have potential mortality associations. So it's important for students, even if they don't know exactly what it is, for instance, like a delta wave or a Brugada pattern, they can at least look at that and say, I'm not sure what's going on, but it doesn't look right. And that's a great place to be when you're learning. So that's all I have for our presentation, and I'll stop here and take some questions.
Yes, we have a question from a participant. At what point in the didactic year do you think it is best to cover EKGs? Do you think it is more effective to teach it after the students have covered cardiology and clinical medicine?
I think so, yes. I cover it at the end of my cardiology module. So I do all of cardiology and clinical medicine and patient assessment. And they also have, we use a clinical decision making, which is just a case-based course. And I find that EKGs work best at the end of that, because as I mentioned, with there being so many abstract concepts, anytime you can tie it into something they feel like they can like grasp and touch, like a clinical correlate, that works really well. So they've already had anatomy, they've already had physiology. And then if they understand concepts from clinical medicine as well, then it makes it a lot easier for me to talk about things like ischemia being a potential concern for a long QT syndrome or a long QT interval, for instance. So that's, I think covering it after they've had cardiology makes it the easiest to grasp.
Thank you. Another question, does your textbook come with other teaching tools such as PowerPoint slides or something online?
It does, yes. So there are PowerPoint slides available for you to use to incorporate right into your lectures. The other nice thing that I think about the book is that there's loads of case studies and questions. So you could just You could fill a class period just with the last chapter in the book, which gives you a clinical scenario, and then there's an EKG, and there's teaching points for each one of those. So gives you all the interpretation following the rate, rhythm, axis, infarction, block, and then also teaching points that I think are helpful little pearls. So you really could very easily just work that right into a lecture.
Thank you. I'd also like to mention that the book does come with online access for students as well. Another question, what clinical conditions are you most concerned about with a long QT interval?
So it's a great clinical correlate that you can make. So with a long QT interval, that's a can't miss mortality risk. So we think about ischemia, the potential for ischemia, hypokalemia, or other electrolyte abnormalities, specifically hypokalemia. And then you're worried about medications. So especially now in the age of polypharmacy, in particular with elderly patients, there are clear classes of medications that when you start combining them, you really increase your risk of increasing that QT interval, which predisposes to things like polymorphic BP. So things like certain classes of antibiotics, antidepressants, antifungals, antipsychotics, and of course, antiarrhythmics, or things that your eyes should just kind of glance over their med list for.
Thank you. Another question, could your book be used for primary care nurse practitioner students?
Absolutely. So the book was written really for that exact demographic. So for NP students, PA students, I cover the basics of everything that I think you need to know as an electrophysiology PA, and I've been a preceptor for years. And so I really wrote it from the lens of what questions do students have? What things do students struggle with when they're out on rotations, or even when they're new practitioners? And so it really starts at a very basic level and builds up through each chapter. And you could take it and really make it as much or as little as you want, depending on how in depth, or maybe you want to go less in depth. But it's certainly designed for just that purpose.
Thank you. And looks like just one more question here. How does evaluating the P wave help determine the correct interpretation of many rhythm disturbances?
So I like to say that the P wave is kind of the underappreciated champion of the EKG, because we think so much about ST segments and injuries and infarcts, which are certainly important. But if you really understand how evaluating that P wave and its relationship to the QRS really defines things like AFib, A-flutter, different types of SVT, ventricular tachycardia, it really does hold the key to your diagnosis for just about every arrhythmia. So understanding how I can incorporate that into my systematic approach. And I think doing it early in that rhythm section of your approach can really help you narrow down, and oftentimes can make the diagnosis for you.
Thank you. That looks like the end of the questions. So we have reached the end of our webinar, and I'd like to take a moment to thank Maureen Knechtel for her presentation and all of you in attendance for your participation. For those of you who are interested in seeing a sample chapter of EKGs for the nurse practitioner and physician assistant to review for your course, you may do so by visiting the first link on this slide. For more details about adopting this book for your course, you can visit springerpub.com/educators to contact your sales representative. Or to purchase a copy at a discount, you can use the coupon code on this slide. This webinar has been recorded and will be shared with all participants in about 5 to 7 days, and will also be posted on our website under the video section for future reference. I hope you all have a wonderful day.